going to go ahead and get started. Welcome to today's webinar, Work Conditioning versus Work Hardening. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts. We're excited you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in planning our educational resources. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our host, Cynthia Borbo. Cynthia Borbo is president and founder of Medical and Life Care Consulting Services, MLCC. She's a registered nurse and certified rehabilitation nurse, a case manager, a nurse life care planner, a legal nurse consultant. She has worked as a nursing professional for 40 years and currently leads Medical and Life Care Consulting Services, a practice of nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and other ancillary professional nurse consulting services. As a nurse life care planner, Cindy has completed hundreds of life care plans, life care plan critiques, and life care plan projections, medical cost projections for plaintiff and defense and insurance companies, and supported patients and clients throughout the United States. Cindy founded Medical and Life Care Consulting in 2001 and is presently a member of the American Association of Nurse Life Care Planners and a board member of the CNLCP Certification Board. She's also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. At this time, Cindy, I'll pass it to you.
Hello, everyone, and thank you for joining us today. Before I hand this over and introduce Colleen, I'd like to share a little bit about the Injury Insight program. Injury Insight's a four-part webinar series designed to educate claims professionals, HR resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments both common and uncommon within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So get your questions ready. For this session, the first of this year, we're doing work hardening versus work conditioning. Understand the differences, similarities, and where they fit within the claimant's rehabilitation and recovery. We're pleased to have Colleen Medlin of Professional PT here. Colleen has a bachelor's of health sciences, a master's in physical therapy, and a doctorate in physical therapy from Misericordia University. She had multiple experiences as a successful facility director prior to assuming a multi-site director role in Maryland while with Physiotherapy Associates. During Colleen's clinical and operations career trajectory, she became certified to perform functional capacity evaluations, certified ergonomic assessment specialist, a certified injury prevention specialist, and honed her academic focus on workers' compensation and work rehabilitation. As Colleen performed these services and built relationships with referral sources and payers, she became recognized as a leader in this field and transitioned to a role of regional workers' compensation clinical specialist with Physiotherapy Associates. Based on multiple requests for her expertise, Colleen also founded CAM Peer Review, LLC, which perform utilization review of physical therapy treatment, medical necessity, and billing. Colleen assumed the role of Regional Director of Work Strategies after Physiotherapy Associates was acquired by Select Medical and increased her focus on payer relations, including managing the relationships with various networks in the industry. She was then hired by Phoenix Rehabilitation as Director of Clinical Operations for Workplace Health and Workers' Compensation. This expanded her knowledge into occupational medicine and expanding her focus on working with employers and reducing OSHA recordables. Colleen now works as the Director of Workers' Compensation Clinical Services for Professional PT. Her focus is on providing a comprehensive workers' compensation program clinically to meet the needs of the employer, physician, case manager, and insurance company. She also works with employers to help evaluate and manage their injuries and safety in the workplace. Thank you so much for joining us today and for sharing your knowledge today, Colleen. I'm excited that you're here, so thank you.
Thank you.
I'll turn it over to you.
Thank you for asking me to do this. It's a pleasure to be here. So, all right. There we go. Gotta love technology. It's not always my friend. So thank you guys for all being here. So as everybody said, I am going to be speaking about work conditioning and work hardening, kind of what's the differences, what should you guys look for, those types of things. Upon completion, you guys will have a deeper understanding of a return to work program, how to recognize work conditioning and the components, understand the differences in work conditioning and work hardening, and explore the benefits of a work conditioning and work hardening program versus acute therapy. I think that's where we tend to kind of get things a little confused. So I think we all know this claimant. I think we've all seen them, the person that once they're out of work, they're just sitting on the couch, they're not doing anything. I like to joke that they're laying on their couch eating their bonbons. In this case, drinking their beers and having some pizza. But you know, what ends up happening with these patients? They become very deconditioned because they're not active. And if you think about a lot of these injured workers, they have physically demanding jobs. So if they're going from doing their work every day, you know, 8, 10, 12 hours a day, to then just sitting on a couch, it is very easy. We lose our muscle strength very quickly. So it is expected that as soon as somebody is out of work for a week, 2 weeks or so, you're going to start seeing a difference in what their body is. They're going to have decreased strength, endurance, and tolerance for their job demands. When there was recent research done and they looked at what is the likelihood of somebody returning to work, is a 55% chance returning to any meaningful employment. So that means not only just the fact of necessarily the job that they were injured on, but any type of meaningful employment, whether it is a police officer going back to a desk duty, or whether it is somebody who is going back to their full duty. If they're out for 1 year, it decreases to a 32% chance. And then by 2 years, it's a 4.9% chance. So as you can see, it's really important for us to have that focus on return to work and try to get them back as soon as possible. And there's different ways of looking at that. It doesn't necessarily mean that we have to get them back 100% quickly, but getting them back to work to some capacity. So what is a return to work program? It's an aggressive loss control program designed for employers, case managers, and adjusters who want to facilitate safe, efficient, and effective early return to work for workers' compensation claims. So it's important to make sure that when you're looking at a return to work program, you're partnering with PT and OT clinics that really have a very good understanding of work comp and what it takes in order to get the patients back. You know, there's a lot of clinics out there that their primary focus is on the commercial insurance patient. And the focus when we look at a commercial patient versus a workers' compensation claim, they are different. There's a different thought process behind it. Not that that takes away from anything, it's just a little bit different. So what are the key elements of a return to work program? First of all, early intervention. Case facilitation for early return to work. So we want to make sure that we're identifying their essential job functions. And you'll hear me kind of go into that a little bit more once we start talking about work conditioning as well. You want to identify if there's a modified or light duty at the employer. And, you know, again, one of the things that, you know, Cindy said that my background is part of also working with employers. So maybe if an employer doesn't have a light or modified duty, it's working with them to come up with some potential options so that that injured worker can get back to some capacity as well. And also identification of their current functional abilities. So where do they stand when they're starting their therapy? Or maybe you're looking a couple weeks in, what is their current functional status and where do we need to get them to? What is that baseline that we need to get them to in order to go back to modified or light duty or to return to full duty as well? The key elements continued. You want a treatment program with an emphasis on active versus passive treatment options. I think a lot of times as therapists, me being a physical therapist, I can say these things, is that we tend to do a lot of manual therapy. I think that over the years, the modalities are starting to get phased out. There's still time and place for modalities as well. But it's really important with work comp cases to really focus on the active treatment, having the patient learn how to manage their pain on their own as well, and not necessarily getting stuck on getting that soft tissue massage 3 times a week. Don't get me wrong, I'd love to have a massage 3 days a week too, but it's more important to make sure that we're focusing on their essential job functions. We want to make sure that we're including job simulation. So we want to start including that as early on as possible. As things have changed over the years, I've been a physical therapist for 23 years now. And when I first went into work comp, everybody wanted to go back to work. I didn't have this fear of returning to work. I didn't have these high pain complaints that you guys hear now with a lot of these cases. So it's just a much different thought process. And I would say that it's changed over the past probably 10 years. So the sooner we can start doing things to simulate their jobs, even if it's just as simple as squatting down to, you know, mimic picking something up off the floor and then putting it onto a shelf, the better we're going to be to show them that they can do those functions. We also want a partnership approach, and you're going to hear me talk about this a couple times throughout this presentation, but we want to make sure that we're working with the physicians, the case managers, the adjusters, to all make sure that we're on the same page and that the focus is the same and that the goals for the rehab are all in agreement, and also making sure that the patient understands what the goals are as well and that they're on board with what the plan is. There's full product offering for all phases of rehab, and I'm going to talk in a second about what those phases of rehab are. And again, to me, one of the most important things is the effective communication with all stakeholders. There shouldn't be anything that is an unknown in a work comp case. We should all be on the same page, have a clear understanding of where the cases stand. I find that sometimes, like Cindy said, I have my own peer review business, so I do read a lot of PT notes, and sometimes I just don't think they always paint a clear picture. Sometimes I think that is things just get omitted for, you know, if there's inconsistencies or that kind of stuff, but it's important to make sure that we're communicating with each other. If, you know, a case manager has concerns or an adjuster has concerns about a case, that they're communicating those things with us as the therapist as well, so that we are all on the same page and are aware of any concerns that there may be with a case. So talking about the phases of a return to work program, phase 1 is the acute management or the subacute management, and then stay at work strategies. So that education aspect. So what can we do to keep them at work? Ideally, we want to avoid having them out of work. And I think us working with the physicians, the adjusters, and also looking at the employer to get that communication, we can avoid having people out of work. Phase 2 is that work conditioning or work hardening phase. This is the focus on the essential job functions, looking at job simulation, and also looking at that conditioning aspect, which is super important. Phase 3 is the advanced testing for case closure as well. So not all cases will need this, but looking at the potential of functional capacity evaluations, or even a job site analysis. So what is, looking at work conditioning, what are the successful elements of a work conditioning program? So you're going to see this slide again because I think this information is super important for us to discuss. Work conditioning and work hardening are terms that are most utilized in the medical community, and most referrals are for a work conditioning program. However, over the years, these terms have kind of become a little muddied in the water, and I'm going to talk about that coming up. But it's important for us to communicate with the referral source and understand what the objectives are to get an idea of, is it work conditioning or is it work hardening that they're truly looking for? We want to utilize a team approach, including the patient, the therapist, physician, employer, insurance carrier, and the case manager. That multidisciplinary model. And I think a lot of this has fallen to the wayside. I think, don't get me wrong, I think there are situations where it is that maybe the case manager, the physician, and the employer are having conversations, or the adjuster is involved in it. I don't find a lot of times that us as the therapists are involved, but it's also on us to make sure that we're communicating and documenting well so that it's very clear where the case stands. Also, the program should not focus solely on the injured body part, but address the patient's entire range of physical capability as related to their job. So once you get into looking at that work conditioning or work hardening program, it's a full body approach. So we're not solely focused on that specific injured body part, because again, they have now been out of work. Other joints are maybe not working the same way they used to, because, if you go from working in a warehouse 10 hours a day, 5 days a week, to all of a sudden sitting on a couch for 6 weeks, that's going to have its impact on your full body, not just the body part that you injured. So work conditioning is an intensive work-related, goal-oriented conditioning program designed specifically to restore systemic neuromusculoskeletal functions, motor function, range of motion, cardiovascular pulmonary functions. So if you're looking at that, it's impacting our whole entire body. And the goal is to restore their physical capacity and function to enable the patient or client to return to work. That is our ultimate goal. So work conditioning is an alternative to work hardening. One of the things, and again, like I said, I'm going to go into work hardening a little bit more coming up, but really with work conditioning, the primary focus is on that conditioning aspect. You don't necessarily have a multidisciplinary approach. And again, like I said, I'm going to talk about work hardening and what that means for work hardening coming up. It's a single discipline. So it's really looking at PT or OT and having that focus on that. It's ideal if they're not working at all, but you can also do work conditioning. If somebody is working part-time or on modified duty, we can work with an employer to still get that work conditioning program started as well. Gigi, do you want to throw the poll up? Perfect. So if you guys can fill
All
up.
right. Yes, please take a moment to participate in the poll. We'd love to get 100% participation. Don't worry, the answers are anonymous, so we're not checking to see who passes the test or not, but definitely want to get an understanding of what you know. All right, we're going to close the poll down in about 5 seconds. 3, 2, 1. And there you are, Colleen.
Okay, so I may be slightly mean by this question. So I always like to see this just because I think, I do a lot of training like for our internal clinics as well. And I ask them how long they think a program should be. So really, there's multiple answers here that are correct. There's one answer here that I don't particularly like, but we seem to see it happen a lot. So I'm going to close this and I'm going to talk about these answers. So there we go. Sorry, my computer wanted to be a little bit slow. So ideally, when we're looking at a work conditioning program, it should be 3 to 5 days a week. If somebody is not working, it should be 5 days a week. When they come in, we're going to start them off, typically speaking, at 2 hours and build up to anywhere from 4 to 6 hours, depending on what the goals and objectives are. So as you can see here, I said that the duration is 2 to 4 weeks, but up to 8 weeks if necessary. So this is where it gets a little tricky and where I think things have kind of fallen to the wayside when it comes to work conditioning and work hardening as well, is that I think that there's unfortunately a lot of PT providers out there that when they say that they do a work conditioning program, they're really just doing an extension of the acute program. So they're really not building to a true work conditioning program. So I think it's important when you guys are looking at your cases, and if somebody is requesting work conditioning, making sure that the clinic has the capabilities to provide a true work conditioning program. When you are looking at this, it's one of those things where they should be about 60% from their goal to, like, when it comes to maybe like lifting a box and the weights that they can do. I'm going to use like a really simple math equation from my head. So like if somebody has to lift 100 pounds in order to return to work, if we're going to transition them into a work conditioning program, we would want them to be at least 60 pounds, because ideally we want to have them discharged from that program in about 4 weeks. I'm not opposed to 8 weeks, but unfortunately, I think over the years, a lot of the work conditioning programs have been extended out anywhere up to that 12 weeks or so. So just kind of keep that in mind when you're looking at work conditioning. We also have to have authorization to perform separate from acute therapy. It involves the exercises and work simulation, and it is a self-paced program. So when they're coming in, there's very specific objectives that they're given, and we go over that. So looking at the program entrance criteria. So how do we determine if somebody is appropriate for work conditioning? So first of all, we want them to have a job that falls into the medium to very heavy physical demand level. So obviously somebody who has like a sedentary job, maybe it is the front desk at a dentist's office. They're not necessarily going to be somebody that is appropriate because of their level of work. When you're looking at it, you're really looking at those people who fall into warehouse workers, construction workers, police, fire, those types of things. So those are going to be the ones who are more appropriate. We typically speaking want them to have a return to work goal. I will say that over the years of doing this, I have seen cases where they may not have a job that they're going back to, but the case manager or adjuster feels that it's really important for them to go into a work conditioning program to kind of hit that highest level of function possible. We want them to have a willingness to participate and have active engagement. I think we all have seen that work comp case where the patient doesn't want to do anything. They don't want to get better. They don't want to go back to work. That's ideally not who we want to send into work conditioning, because ultimately you're not going to get the outcomes that you're really looking for. And it'll probably frustrate everybody more than actually help the claim. We want that person who, has some sort of motivation to go back to work, who has been actively engaged in their acute program and so forth. We want them to be medically stable. So, that doesn't mean just necessarily high blood pressure or their blood pressure or their heart rate, but also looking at things like, are they going to have any more, like say it's a back injury, are they going to have any more injections? If somebody is still in the process of getting treatment such as injections, we don't want to start them on a work conditioning program, because the physician is going to take them out of therapy for at least a week for them to heal from them. There is a systemic neuromusculoskeletal physical and functional deficit impacting their work. So there's reasons why they can't return to work related to their function. It typically does not begin earlier than 30 days following the date of injury. we have a referral from the physician, and they're not working full duty. Obviously, if somebody's working full duty, we would not want them in the program. Some of the referral indications: the patient is off work due to injury or working limited or modified duty, minimum of 4 weeks since the date of injury, but typically speaking, you're going to see more like 6 to 8 weeks. The patient cannot demonstrate ability to safely perform 100% of their essential job functions, and this is keeping them from returning to work. Patient has limited strength or endurance. There is a pain focus or self-limiting. So again, we can use this to motivate them a little bit more. The job is physically demanding. That goes back to that medium to very heavy physical demand level. Patient has plateaued in conventional therapy. So this is a big one that I think a lot of people don't realize, is that sometimes you're going to hit that plateau when it comes to acute physical therapy or occupational therapy. And a work conditioning program is a good way to get them over that hump. You're going to give them a more intense program, and it really just kind of helps to get them over that plateau. And typically speaking, when they hit that plateau, the biggest plateau is with their strength and their abilities to meet their job functions. So this will really help with that. Or patients who report a fear over return to work and re-injury. This is, like I said earlier, this is a very common thing now over the past 10 years. So again, if we can replicate their job demands in the clinic and show them that they're safe, their body is okay to do these things, that they're not going to re-injure themselves, we're going to have better outcomes as well. So this is just something that I had put together for our clinicians. So it's just kind of a simple, easy checklist. Yes or no. The clinician goes down and marks these things off. And these are kind of the things that we were just talking about. And it gives them an idea of, is this patient appropriate? Because again, a lot of this comes down to the therapist also communicating with the case manager, the adjuster, and the physician to recommend work conditioning if it's appropriate. We are the one who is seeing them so much more than everybody else. So we'll have a clear picture. So again, it's important for us to make sure that we are transitioning somebody when it's appropriate. So this is one of my biggest things, and I think our clinicians within the professional physical therapy cringe every time I talk about job descriptions. But job descriptions are super important. I emphasize the importance of job descriptions, not only with work conditioning or work hardening, but also with our acute rehab as well. And you did hear me kind of reference it at the beginning when I was talking about a return to work program. It's really important for us to have these job descriptions so that we know exactly when they're supposed to be returning, what their job demands are, so that we know when for the return to work. If we don't know what those job demands are, it's kind of hard for us to truly be able to tell them when, or the physician making that recommendation. Unfortunately, as you guys probably are very well aware, not all job descriptions are good. A lot of the information is more like, must have a high school diploma, or those very generic statements. So we're really looking at more, what are their job demands, so that we know what to go back to. Yes, thank you.
All right, let's take a shot at poll number 2. Regarding job descriptions, the client is a reliable source to obtain job demands. True or false? Let's see if we can get to 100% participation. I think we're about there.
Yay.
Almost. Okay. This poll will close in 3, 2, 1. See how they did.
Okay. So thank you guys for all answering. I appreciate that. Okay. So let's talk about this. This is one of my things that, it's when I started with ProPT, they really weren't getting job descriptions, and I put a very large emphasis. And one of the things that they had the injured workers doing when they started with us was filling out what their job demands were. And then the clinician would basically set up their goals based upon what they had listed as their job demands. Unfortunately, I don't always think that the patient is a reliable source. And it's not that they necessarily are trying to be deceitful in what their job demands are, but they a lot of times just don't know what different things weigh. So one of the things that I've always done is I sit there, and when I do like a work conditioning training or even just a general work comp training or an FCE training, I'll take a lift box, I put weights in it, and I have every therapist lift it. And they have to then report back to me as to how much it weighs. Most PTs will claim that they are smart individuals. And I can tell you, in all the years that I've been doing these trainings and having them do these things, I've only had 2 clinicians ever get the weight right. So when you look at what a lot of these injured workers are doing, they are picking up awkward things. They are maybe picking up a bag of objects that is shifting around. And it is very hard for people to determine what items truly weigh. So it's just not the best in order to get them to tell us what their job demands are. I had a situation where we were trying to transition a patient into work conditioning. Patient was a truck driver, and they were taking packages off the truck and that kind of stuff. They had reported that they had to lift 100 pounds. I had one of our admin people reach out to the employer to just confirm what the job demands were. We use a form like this, which I call an abbreviated job task analysis, where the employer completes what the job demands are. When the employer completed this form and sent it back to us, their lifting requirements were 0 pounds. So as a driver for the company that he was working for, all he did was solely drive. He had another person on the truck who was doing all the lifting, carrying, pushing, pulling, all of that kind of stuff. So we were able to, at that point, basically reach out to the physician and tell them, hey, this patient is appropriate to return to work. Work conditioning is not appropriate. So, it's just one of those things to make sure it's important. So we utilize this form. We still do ask the patients what their job demands are, but I just tend to recommend taking it with a grain of salt, just because also some patients will say that they have to lift 150 pounds, let's say. And then when you actually get to talking to the employer, it may be that they have a crane that they're supposed to be using, but they don't use it because it takes 2 seconds longer than it does for them just to physically try to pick it up. Another resource that we tend to use when we're trying to go through the process of either communicating with either the case manager or the adjuster or the employer is we'll reference the Dictionary of Occupational Titles as well to see what the strength requirement is for a specific job. So there are other resources besides just utilizing the patient or the job descriptions. One of the things that I did reference was also making sure that they're medically stable. We do want to make sure that if there are blood pressure or heart rate issues, that we do receive medical clearance, just to make sure that we're staying on the safe side, because we are having them do high level activities, a lot of lifting, carrying. So we want to make sure that we are safe when it comes to it. Another thing that we utilize is a biopsychosocial questionnaire. For us personally, we utilize the Orebro. This is a 10-question questionnaire that identifies delayed or incomplete recovery. So it's looking for those yellow flags, and it's scored on low, moderate, or high risk. So, the reason that we do this is that when it comes to work comp cases, 10 to 20% of the cases are those complex patients. And these complex patients make up 80% of the spend for work comp cases. So if we can start identifying these cases earlier on in the treatment program, the better the outcomes can be, because we can have better communication with everybody involved on the status of these claims. So going into work conditioning, what does this look like? Assessment-wise, you're going to do all the typical stuff. Intake interviews, subjective, past medical history. Then you're going to do the musculoskeletal exam, looking at gait, posture, range of motion, flexibility, and strength. However, that being said, you're going to do kind of a little bit more in-depth evaluation of the injured body part but you're going to do a full body screen as well, because again, maybe they had a past, they're coming in, their injury was for their shoulder, but maybe they had a past injury to their knee. So maybe their squatting is a little bit different. It's important for us to know those things going into the treatment. Aerobic capacity assessment, and I'll kind of talk to you about that coming up. Material handling or lifting assessment, and then positional tolerance or non-material handling assessment. So this is just looking, I referenced this before, is the physical demand levels. You can see what those lifting requirements are here. You have typical energy requirement. So this is going into looking at their cardiovascular ability. So there are some jobs that will say what level of METs somebody has to be at in order to return to work. So one of the tests that we typically utilize for this is the Bruce Protocol treadmill test. So that's looking at a VO2 max. You can utilize that to then go in and look at their METs level and determine if they meet the job demands. Documentation, you want to establish goals, frequency, and compliance expectations. Talking about frequency is another big thing. Like I mentioned before with it, you typically speaking want to see them 5 days a week. Every once in a while, we'll get a prescription that is like, okay, work conditioning 2 days a week. Again, that should be a communication between the therapist, the case manager adjuster, and the physician to determine really what they want. Like I said earlier, is if somebody is out of work, they really should be coming in for work conditioning 5 days a week, so that ideally we can get them into that work conditioning program, do about 2 weeks of it, and get them back to work. We want it to be a goal-oriented program. You're looking at strengthening, conditioning, endurance, aerobic capacity, job simulation, work style modification, and symptom relief through education. So again, it's one of those things we want to get in a work conditioning program. We should not be doing manual therapy at that point. We should be educating that injured worker on, if they start doing a lot and they start to get sore, what can they do to eliminate those symptoms that they are having? And then potential lifestyle changes through education as well. Treatment plan is based on the deficits of the essential job functions. So examples are decreased lifting, decreased standing and walking tolerance, basically looking at those essential job functions. This is just some example goals. A short-term goal could be able to lift 20 pounds frequently or increase walking tolerance to 30 minutes. But again, all of these goals should be related to their essential job functions. The goal of the initial evaluation is to determine the patient's appropriateness for work conditioning. There are some instances when we may get a work conditioning referral in the clinic that maybe they've had acute therapy at another company or something, and maybe they come to us and we might not always think that they're appropriate. But that again would be that communication to determine that at that point. We want to identify the patient's individual functional work tasks, conditioning, and musculoskeletal requirements. Again, working with the job description, the employer, case manager, adjuster, whoever we need to try to kind of determine those requirements. We've designed the program based upon the deficits and outline for discharge to return to work. So this is just kind of going through what are those components of the program, and we're going to kind of go through this. So this is just kind of also showing you guys some different examples of equipment we may be using in the PT clinic. The two on the left are different types of sleds. You have different types of lifting boxes. The one in the middle and the bottom is more for a one-hand carry. You have, both of the middle ones are one-hand carry. And then you have in the upper right corner is a lifting station. So you can see that those shelves are adjustable so that we can change it based upon the person's height or whatever the job requirements may be. Orientation is super important. It's really, the injured worker has to have an understanding of what the expectation is with a work conditioning program, because it is much different. Really, it should be much different than an acute program. Explaining what the attendance is. They should continue to take their medications as prescribed, their attire, We want to make sure that they're coming in attire that they're able to do the physical requirements. If it's somebody who has specific job attire, we want them to bring it. So like if it is somebody who's working on a construction site and wears steel toe boots all day, I want them in their steel toe boots. There's a big difference in walking around in tennis shoes for 8 hours versus walking around in steel toe boots for 8 hours. I wear them when I go on job sites and boy, my legs are tired. So we want to make sure we're replicating that. If somebody is, let's say, a firefighter, we want them to bring in their turnout gear. You know, that weighs anywhere from like 50 to 75 pounds. So if you think about it, if we have them doing steps as part of their work conditioning program, having that gear on is important. Or, you know, if they don't have that to bring in, use a weighted vest, those types of things. I'll say it was funny. I had a friend who was treating a firefighter, and one of the things that they did with him was because of weight requirement and, you know, having to carry people or drag people, he was having him drag himself as the therapist around the clinic. So it's kind of funny to see that picture. Explain the patient responsibility. So what are their responsibilities? This is an independent program, but it's supervised. They are responsible for pacing themselves, doing the activities, following the instructions. When it looks at like program development, we're looking at having a warm-up, strength training, functional training, and cool down. So that's just kind of giving you some approximate timeframes. And then you can take and build the program based upon how many hours it is. So when you're looking at these programs, they should be increasing every week. So the program should start at about 2 hours for the first week. By week 2 of the program, you should be at 3 hours. And by the 3rd week, you should be at 4 hours. If they needed to progress beyond that, then we would still keep increasing based upon 1 hour each week. And it's also important to make sure that we're increasing their weights. So that work simulation, you should see a 10% or 10 pounds increase every week with their lifting abilities. And that's super important for that to occur in order for that program to be done in that 2 to 4 week time frame. So I just included in here some sample programs, you know, looking at 2 hours, 3 hours, and 4 hours as to what that might look like. Daily documentation and progression. Obviously, everything has to be documented. That's no different than any acute therapy. One of the big differences, though, is that typically speaking, what happens with a work conditioning program is that the patient is given a paper flow sheet that has their work conditioning program listed on it with how many repetitions and what the weights are going to be or time, those types of things are listed on it. And as that injured worker is going around the clinic and doing their program, they should be marking those activities off when they are completed. And then the therapist at the end of the day should be reviewing it. Again, education is part of this program as well. A therapist should be documenting what their tolerance was or attitude or compliance. I had an injured worker one time where I would hand him his flow sheet. I would come back and I would check on him and I'd look at his flow sheet and he would change all the weights. If I had 50 pounds written down, he would do 35. And it was, you know, so me and the case manager were having consistent conversations about, you know, his attitude and compliance with what the program was that he was designed. There should be weekly progress updates. So typically speaking, I think when you look at acute PT, there are some companies that do progress updates once a month. So typically speaking, every 30 days. There are some companies that do bi-weekly updates. But when it comes to a work conditioning program, it should be weekly updates, because if a patient is not progressing weekly, then we really need to reevaluate what's going on and communicate with the other stakeholders to understand, like, okay, what is our plan? And especially if somebody is not progressed after 2 weeks, then we really need to put a halt on it and kind of figure out, reconvene, okay, what is our plan with this case? Like I said, those progress notes, once it comes to a work conditioning program, you're really not going to see the range of motion measurements and the strength measurements, you're really going to see more the updates on their essential job functions. So what is their material handling abilities? How much can they lift from floor to waist? How much can they carry or push or pull? And then you're also going to see the non-material handling or positional tolerances as well. You should see an update on their goal status and then any assessment or recommendations at that point, or continuation or discharge. With discharge, you should be seeing a justification for that discharge. You know, what is going on? Did they meet their goals? Where does all that stand? So benefits of work conditioning: it bridges the gap between acute therapy and return to work. It allows the patient to return to their highest level of function. It focuses on their essential job functions and conditioning combined, and it helps to motivate that patient to be independent with the management of their injury and symptoms. So we kind of really went through work conditioning. So what is the difference between work conditioning and work hardening? So first of all, one of the key things, I'm going to go through kind of the difference in the two, and then I'm going to talk about what the terms and how that kind of changed over the years. So work conditioning, we've kind of gone through all this. They're medium to very heavy physical demand level, 3 to 5 days a week, anywhere from 2 to 6 hours, separate from acute therapy, work stimulation and conditioning, and it's self-paced. Difference with work hardening is, typically speaking, it's going to be 5 days a week, and you're going to build up to 8 hours a day in the clinic. I think that is a daunting thought process for everybody involved. I think, you know, as a patient, they get overwhelmed by the fact of potentially having to be in the clinic anywhere from 2 to 4 hours, much less when you tell them that you're going to build up to 8 hours. But one of the biggest differences with work hardening is that it's typically speaking considered to be a multidisciplinary approach that involves psych or voc rehab as well. That being said, the vast majority of the time when somebody is making a recommendation for work conditioning or work hardening, if they say work hardening, they're really, typically speaking, looking at the therapy aspect of building up to 8 hours a day, not necessarily the multidisciplinary approach. So that's why it's so important to have these conversations. And over the years, ultimately, the terms have become interchangeable, not on purpose, just, you know, a lot of physicians will write work conditioning / hardening. And it's like, okay, well, they're two different things. They get billed the same, but they're two different things. So a lot of times it's that communication to find out what is it that is the goal? What is it that that stakeholder is looking for specifically? So what we have learned, value of a full program. It's important for us to offer a full work conditioning program. Like I said, it is truly different than an acute program. So you want to make sure that if you have clinics that are doing work conditioning, that it is a true work conditioning program. And when you get the documentation, you should be able to tell that based upon the activities that they're doing. They should be doing those things that are that material handling, a lot of conditioning, all of that. More frequent and goal-oriented treatment produces better results. So again, making sure that they're getting in that 5 days a week. There was a research study from 2017 that showed the following benefits of work conditioning and work hardening. A significantly higher number of participants were working at the end of the program than at the beginning. So almost 84% compared to 31%. The mean strength was higher at the time of just discharge compared to at admission. Participants that did not return to work had significantly more days off work prior to the program. So then again, you know, that's going back to what, you know, one of those very first slides that I talked about those return to work outcomes. And the return to work rates at the work rehabilitation program broken down by type of injury were 84% for upper quadrant injuries, 81% for lower quadrant, and almost 85% for spine, which honestly, when I was reading this study, that kind of blew my mind because I think most of us cringe when we get a spine case. So what we need to get started, obviously we need that referral stating work conditioning or work hardening. We do a medical screening checklist to, again, just make sure that they are medically stable. We need to get that authorization so that we can do that program as well. Again, this is that slide that I said you're going to see again. Elements of a successful program. utilizing that team approach. I've said it a million times now in this presentation that it's so much about communication with all the stakeholders to make sure that we're doing what is best for that patient and what the goals are. It shouldn't focus solely on the injured body part, but address the patient's entire body. And like I said, the work conditioning and work hardening terms are most utilized, but most of the time they're looking for a work conditioning program. But it is important to communicate with the referral source and understand what the objectives are when they wrote that prescription. So this is just kind of a brief, like what is the successful program? And it just kind of goes through those types of things that kind of like all of it condensed into one slide when what you're looking for work conditioning wise. Teamwork is key. Everyone has to be aware of the goal from time of referral to discharge to return to work. All members of the medical team must work together to achieve the desired outcome, and frequent communication is critical. So in conclusion, work conditioning can be a valuable tool for the patient, clinician, physician, case manager, adjuster, and employer to facilitate a safe and expedient return to work for patients with physically demanding jobs. And a work conditioning program can be an effective strategy to positively impact fear avoidance behaviors, as well as physical and mental hurdles to recovery and successful return to work. Any questions?
Awesome. Thank you so much, Dr. Medlin, for sharing such great information. At this time, we will shift into a question and answer session. So please utilize the Zoom question and answer function at the bottom of your screen to submit your questions. And if you don't have a question, but we're standing by to listen to some of the awesome questions that come in, I do encourage you to scan the QR code that you see before you. It'll take you to a really brief survey. If you could complete the session survey, we'd really, really appreciate that. All right, so let's get started with some questions that have come in the queue. Here's a good one. What are the most frequently seen workers' comp diagnoses that need this program?
Okay, so you got to throw out a tough one for me. Okay, so here's the thing, is I don't necessarily feel like nowadays it's a certain diagnosis. When you're looking at the research out there, the shoulder, knee, and lumbar spine are the most commonly injured body parts. And they typically take, I would say shoulder and spine, depending on what the shoulder injury is, spine especially, take a long time to rehab as well. So I feel like those would be the top. However, like I said in the presentation, I think part of it also goes into what type of job is it? So that's going to be a big impact on it. But I'll tell you, honestly, one of the patients that I feel like should do more work conditioning than occurs are hand cases. I personally feel like hand cases get, I don't want to say drug out because that makes it sound bad. They just take a lot longer for return to work. I get it. The hand is, there's a lot of small tendons, delicate, and you know, when you have maybe a tendon rupture that a physician is repairing or that kind of stuff. But I also think it's super important for when it comes to hand therapy to get away from sitting at that table and using putty and those types of things, and really getting and doing lifting a box or carrying something or pushing and pulling and really doing that with the hand to progress it. Because typically speaking, once the physician gets to a certain point, that hand is stable. It's just a matter of having the patient understand that pain is part of the healing process and that you may have to push it a little bit to, you know, get past it. So I wish I would see more hands going to it because I think we would have better return to work with hand injuries. But I would say typically speaking, you see more shoulder and spine.
All right, awesome. Thank you for that. The next question that we have is, what do you do if the patient doesn't tolerate these programs?
My first thought was cringe, but that's not the answer. So really what happens when a patient isn't tolerating the program, it's a matter of kind of reassessing them, figuring out what is going on that they're not tolerating it. Is it that they're just having increased soreness because now we're pushing them to a different level and their body has to adjust? Obviously, you know, as professionals in this industry, we understand that there's a difference between soreness and pain. And sometimes it's getting them to understand that difference as well, so that maybe it's that they're having this soreness and that scares them because they think they may re-injure themselves. So having that explanation, so looking into it, is it that type of thing? Or is it truly that their body can't tolerate it? So then it's a matter of, okay, is it that they hit a point when we progress them to 3 weeks that they didn't tolerate that increase? So then we have to kind of reassess it. And like I said, time frame wise for work conditioning program, I said was anywhere from like 2 to 8 weeks. So say you progress them to 3 hours and their body just shuts down with it. At that point, I would take them back to doing maybe a 2.5 hour program and see how they do with that. So it's a matter of making those adjustments first before we jump to say either, okay, we're just not progressing them and we're just going to stay here for a while, because that's not the right answer. But looking at it, kind of breaking down where we're having that setback and seeing what we can do so that the patient is still progressing, but maybe just a little bit slower. And then obviously having that communication with the adjuster, case manager, and physician as well, so that they know what we're seeing weekly.
Okay, thank you. As we kind of get down to the last 2 minutes, if there's any other questions, please feel free to use the Q&A segment to submit those questions. And Colleen, if you could transition us to the last slide. Awesome. So the next session is June 14th. This one is on invasive pain management techniques. So if you've not registered for this one and you would like to, please visit our website, www.medicallandlifecare.com/injury-insight, and you can sign up for the next session. Additionally, there was a comment that came in that the survey wasn't working correctly. We've now fixed that, so you will find Colleen's session on there. So if you have not taken the survey, please take a moment to do so. Sorry, Colleen, if you could just go back one more slide for those who want to rescan the QR code. Fantastic. Thank you for being my moderator.
I got you.
Okay. So if there's any other questions, please submit them. And since it seems like the audience is quiet, I will say thank you again. We really appreciate your time today and giving our attendees and our partners such a wealth of information. For those who have attended, thank you for joining our first Injury Insight of 2023. As mentioned earlier, a playback of this webinar will be available within 48 to 72 hours. And lastly, we do ask that you take the time to complete the survey. Cindy, any final thoughts?
No, I had another question, or I had a comment, if you can hear me. Basically, I just find, I was just shocked at the amount, how soon you would start work conditioning or work hardening, because I see so many people in therapy for 6 months and 8 months. And then, you know, it's like, okay, can we just we have to kick it up somehow. We're not getting anywhere this way, right? It's not a question, I guess. It's just a statement. But what do you think about that?
Well, and honestly, Cindy, so it's quite interesting. So I've had a ton of conversations over the years with clinicians. And like I said, I've done a ton of education with our clinicians internally in regards to work conditioning. And, you know, one of the things that I always tell them is, let's start with, I always ask them, like, how many of you wanted to become a PT because you wanted to work with the athlete? And everybody raises their hands because everybody wanted to work with the athletes. And I kind of break down to them like, okay, this is the industrial athlete. Our goal is to get them back to work. So the same way that you break down their sport, we should be breaking down their job. We're not going to drag out an athlete's therapy, and we should not be dragging out a worker's therapy either. I think that sometimes what happens though is that we tend to, if a clinic is more based on commercial insurances, they don't necessarily always think about the fact of, oh, let's transition them to work conditioning. Or kind of like I said, sometimes that concept of having a patient in the clinic anywhere from 4 to 8 hours is like daunting to them. They're like, what do I have to do? What do I do with the patient for 4 to 8 hours? And, you know, I kind of break it down that typically speaking, when you're looking at these workers, their jobs are repetitive. Like all of our jobs are repetitive. So you take it, you make a circuit, and they repeat it until they hit that many hours. And then therapists are like, the light bulb goes off and they're like, oh, it's that simple. Like, and so then they're more likely to transition them. But it's just that thought process of, you know, okay, getting away from the modality, getting away from the manual, and really putting that focus on the job and getting them to transition. And again, I wish that there was better communication with everybody, because I think that we could have these conversations and be like, hey, is this appropriate to transition them now? And, you know, which is why, you know, with all of our work comp, they fill out that checklist, every progress note of, are they appropriate to transition to work conditioning? Because I want it in the front of their brain so that they're constantly thinking like, not just acute therapy, that they're thinking about work conditioning.
That's great. That's so good. In a perfect world, right?
In a perfect world.
Thank you so much. That was great.
Absolutely.
Yes, and with that, we will complete this webinar. Thanks again, Dr. Medlin, Cindy Borbo for hosting this, and for those who have joined us. Have a great day, everyone.
Thank you.